Sir, we are live now.
Yeah. Yes, Saurabh, what are you doing now?
Yes, sir, we are live now. You can start the session.
तो यार तुमने मेरा वो क्यों करवाया था? अभी जब मैंने शेयर किया पीपीटी उसको ऑफ क्यों करवाया था?
वीडियो कवर शेयर करना था ना, इसके लिए सर।
कौन सा वीडियो कवर शेयर करना था?
सर अभी जो वीडियो कवर शेयर किया था ना, वो वाला।
कौन सा वीडियो कवर? I couldn't understand. I can't understand what are you saying. कौन सा वीडियो कवर शेयर किया? Nobody will introduce me. I have to introduce myself.
Yes, sir. Yes, sir. You have to introduce yourself, sir.
There is no moderator.
No, sir. No.
Share this thing. और छोटा दिखता नहीं है ना साइड वाला। नहीं और कम हो जाता है। ये क्लिक करो, ये लास्ट वाला करो। वीडियो तो नहीं दिखेगा। ठीक है। Hi friends, Namaste. Myself Dr. Surikant, Professor and Head Department of Respiratory Medicine at King George's Medical University, Lucknow. And you can see on the screen on the right side, this is the administrative block of White Building, administrative block of King George Medical University. In the middle, you can see the Department of Respiratory Medicine, and on the left side, you can see the greenery in front of the department. So today's topic is management of COPD, that is stable COPD. So before coming to the topic of COPD, you understand the importance of breathing, importance of lung, and importance of oxygen. If you see, we breathe 25,000 times a day, and we can live without food for 3 weeks. We can live without water for 5 days, and we can live without air for not more than 3 days. So that is the truth of life. This is the importance of lung. This is the importance of breathing, and this is the importance of oxygen, and this is the importance of pulmonologists like me. So this is on lighter note. And coming to another important background slide, then I will come to the COPD. Then what is the lung? What is the importance of one pair of lung? God has gifted so many organs in the body, and out of this, there is a one pair of lung with a structurally aerobical area of 100 square meter. 10,000 liter of air passes in and out in every 24 hours, and same amount of blood also passes inside this lung. And this, the net result of this is the delivery of 500 liter of oxygen per day. And that's why the function of lung is called ventilation and perfusion. Now coming to this is the current definition in guideline of GOLD. What is GOLD? It is the Global Initiative of Obstructive Lung Diseases. Means these are the international guidelines for the obstructive lung diseases, and COPD is important obstructive lung disease. These GOLD guidelines gives every year the new guidelines, and they update the older one. The newer definition for 2023 is that chronic obstructive pulmonary disease is a heterogeneous lung condition characterized by chronic respiratory symptoms, that is dyspnea, coughs, sputum production, due to abnormalities of the airways, bronchitis, bronchiolitis, and or alveoli, that is emphysema, that causes persistent, often progressive airflow obstruction. This is the new classification in 2023. The proposed taxonomy for COPD is that COPD can be genetically determined COPD, that is called COPD-G, which can be the type can be the alpha-1 antitrypsin deficiency or other genetic variants with smaller effects acting in combination. COPD due to abnormal lung development, this is called COPD-D, means the early life events, including the premature birth and low birth weight babies, leading to development of future COPD. The environmental COPD, or called because of the environmental factor like cigarette smoking COPD, it is called COPD-C, or biomass and pollution exposure COPD is called biomass-P. Another COPD is this ultimately result of exposure to tobacco smoking, including in vitro or in vivo passive smoking, vaping or e-cigarette use, cannabis inhalation use, or it can be due to exposure to household pollution, ambient air pollution, wildfire smoke, occupational hazards. And next COPD can be COPD due to infection, that is called COPD-I. Childhood infections, tuberculosis associated COPD, now we are call it as TOPD, tuberculosis associated obstructive pulmonary disease. And of course, WHIV associated COPD. So, and the next class of COPD is the COPD and asthma, which earlier we call it as COPD asthma overlap syndrome. This is called COPD-A, and particularly there is a history of childhood asthma. And last, but also important, not the least, the COPD of unknown cause. So this can be, of course, the six important causes, or you see class of COPD: COPD-G, COPD-D, COPD-C, COPD-I, and COPD-A, and COPD-U, and depending upon the etiology. Now, after this classification of COPD, coming to the burden of COPD in India, the estimated burden prevalence was 7.4%. The prevalence was higher among the males in the urban areas and in the northern region, especially in the northeast. There is a high prevalence of smoking. That's why more COPD and more lung cancer in the northeast part of the India. In India, air pollution, both indoor and outdoor, is the third largest cause of death among all other health risks. Coming to etiology, pathology, and pathophysiology of COPD. Now, etiology most of the time can be the smoker COPD or can be the non-smoker COPD. So we have already discussed the non-smoker COPD causes also, for example, COPD-I because of infection, COPD-G because of genetic causes, COPD-P because of pollution or the biomass fuel, and so many other causes. COPD-C because of cigarette smoking. And of course, there is some host factor because we are living in the same environment. And some smokers are there, they will say that they die but did not develop COPD, but they develop some other disease. So which smoker will develop COPD, which smoker will develop lung cancer, who will develop heart disease, who will develop other disease, we don't know. So there is a host factor also. If there's a susceptibility for developing COPD, so they will develop COPD. Roughly 50% of a smoker, they develop COPD, and rest of the 50% is smoker, they develop some other disease. But it is true, it is proven that smokers in due course of time definitely will develop some or other smoking related illness. What is the pathophysiology? Impaired lung growth, accelerated decline growth, lung injury, lung and systemic inflammation. And what is this is all about pathobiology. What is the pathology? Small airway disorders or abnormalities, emphysema, systemic effects. So airflow limitation can be the persistent airflow limitation, or can be ultimately leading to the clinical manifestation in the terms of some symptoms, some comorbidities, and sometimes exacerbations also. Now, what is the air pathology inside? If you just take the cut section of the lung, then you will find there's a, of course, disrupted alveolar attachment. Normally, alveoli, they held open because of certain attachment and they get destroyed in COPD. Mucosal inflammation and fibrosis is there, and mucus hypersecretion is there. And that's why some, of course, variant of COPD, they have more expectoration also. So this leads to loss of attachment, mucosal inflammation and fibrosis, and mucus obstruction of the lumen also. In the sequential section, in first section, this is the normal airway. You will see there is enough space for air passes. There's the inner lining, the middle lining, and of course, in next, there's the airway spas where less space is there. And then as the disease progresses, the swollen middle air there, mucus plugging is there. So as the disease progresses, there's hardly any space for the breathing. Now, a healthy lung compared to a smoker lung, that you can see, and you can see the God has gifted the pink, healthy looking lung, but because of the smoking, the smokers have converted their lung into a dark, then dirty lung. This is called smoker's lung. And a large number of people in India are at high risk for COPD, and a lot of the environmental factors are responsible for the development of COPD. In this picture, you can see the multiple etiology: smoking, biomass fuel, construction, the pollution, because of the so many other occupations and professions. COPD is a systemic disease. You see, in contrary to asthma, which is the localized disease of airway, COPD is a systemic disease. It involves the airway, interstitium of the lung, the pulmonary vasculature, and also have some extrapulmonary sites. So it is not confined only to the lung. Extrapulmonary effect can be the manifestation inside the lung or outside the lung. COPD patient can develop lung cancer also, peripheral lung inflammation also, and there is a spillover of these certain interleukins like interleukin 6, 1 beta, in tumor necrosis alpha, and leading to the skeletal muscle weakness or cachexia, ischemic heart disease, cardiac failure, osteoporosis, diabetic metabolism syndrome, normostatic anemia, depression, and so many other psychological disturbances also. How you diagnose COPD? So we have to diagnose the pulmonary part as well as the non-pulmonary part or extrapulmonary part. So any individual of age greater than 40 years and presence of any of the following should be considered. You see, age is very important. Usually 30 plus or 40 plus are the target population for COPD, while in asthma, usually 75% of asthma cases, they start with the childhood. So here the clear-cut difference. What is the age of onset of symptoms of disease? Whether this is childhood, which is going in favor of asthma, or it is 30 plus or 40 plus is going in favor of COPD. The important symptoms are the dyspnea, which is progressive, persistent, and characteristically worsened with exercise. The chronic cough may be intermittent and may be unproductive cough. Chronic sputum production may be mainly chronic bronchitis disease. It may be less in mainly emphysematous disease. History of exposure to the risk factor may be smoking, may be non-smoking factor. We have already discussed so many factors, and family history of COPD. So these are the 5 points to be remembered. But what is the chronology? Chronology is that morning cough, chronic morning cough is the first alarming symptom of the COPD. Then this cough progresses, it leads to cough and expectoration also, and then in the later stage there comes the dyspnea, and then of course after dyspnea a lot of other complications they can occur and various other symptoms can appear. Now, what is the examination finding on physical examination of the chest? Initially, when you put your stethoscope, hardly there is a breath sound. So breath sound are diminished. Wheezing rarely pronounced as asthma. When you put your stethoscope in asthma patient, you will hear a lot of musical sound. They are called rhonchi. What in COPD, hardly you can hear anything. So breath sounds are diminished. So inspection is more important COPD rather than auscultation. Auscultation is more important in asthma. Auscultation is not so important in COPD. Inspection is more important. And you will find on inspection the signs of hyperinflation. And most important is the reduced cricoexternal distance. Often, normally it is less than 2 figures, which become more during COPD. So, and as the disease progresses, there are a lot of signs of hyperinflation. Because with every breath, there is some retention of air. And that's why the lung, they become expanded. They become larger and larger in size. And to occupy in the chest, they compress the heart, and that's why heart becomes tubular. They increase intercostal spaces, and then, of course, the notch and of the cricoid cartilage, the distance, this become increased, and there's a widening of intercostal spaces, and chest becomes the barrel-shaped chest. So it is not the normal shape of the symmetry of the chest, but it becomes barrel-shaped. Barrel, you see, barrel means the a barrel of the rifle or banduk. Pursed lip breathing. What is this pursed lip breathing? So there is an obstruction, and this obstruction leads to decrease in the expiratory flow. So person is not able to take out the breath completely. Inspiration is there, but expiration gets hampered. So there is this airway obstruction leads to hindrance in the expiratory phase. And that's why person adopts it and he tried to squeeze the lung and so that he can take out the breath out like this. So made the lips like a purse chin or purse lip, the two sides of the chin. So he hold the breath and of course create the extrathoracic pressure, make the lips together and take out create the negative interthoracic pressure so that he can squeeze the lung and so that air can be taken out. That is the main important finding of the physical examination. Now this you can see the barrel-shaped chest. The transverse diameter of the chest disc has increased. So normal chest is elliptical, but this becomes the transverse diameter. Normally the AP diameter is more than transverse diameter, but what happens? This transverse diameter which you are seeing in this picture, this has increased. What happens in chest radiology? So what happens in inspection? A lot of signs of hyperinflation. What happens in auscultation? The breath sound get diminished. So these are the two important findings on physical exam. What happens in radiology? Changes due to enlargement of total lung capacity. So lung capacity get increased because of the elongation of the lung, retention of air, hyperinflation. Loss of diaphragmatic curve. Diaphragm is also a muscular structure, and this elongated lung presses the diaphragm, so it goes down, and that's why there is a loss of diaphragmatic curve. Normally there is convexity towards the lung for the diaphragmatic muscles, and this goes down. This gets ablated. Enlargement of lung fields. So lung fields get enlarged, loss of airway and blood vessels marking, large emphysematous bully, because not only the airway obstruction, there is a airway obstruction, there is a destruction of alveoli also, and that's why there is a large emphysematous bully also on chest X-ray. So this is the chest X-ray. You see the back chest X-ray. So normally you see air is always seen as black on the X-ray. More air, more black. So a lot of emphysematous bulli are there. The more air is there, and that's why X-ray is looking more black. Heart you can see now it is going to become tubular. Diaphragm you can see this diaphragm is actually if you see that, okay, so diaphragm get depressed or becomes flat. So what is the algorithm for the diagnosis of COPD? There is a risk factor. Risk factor can be the host factor, for example, tobacco smoking, occupation-related, indoor, outdoor pollution, and then can be symptoms and host factor, for example, genetic susceptibility and exposure to tobacco, occupation, and indoor air pollution. Symptoms can be shortness of breath, chronic cough, and sputum. And spirometry is a very important tool to diagnose, to assess the severity, and to monitor the disease. So lung function test or spirometry is very important. They're required to establish the diagnosis. So what are the key indicators for consideration of the diagnosis of COPD? Dyspnea, that is progressive over time, characteristically worse with the exercise, and it is persistent. In asthma, dyspnea is never persistent, never progressive, it is intermittent. Chronic cough may be intermittent and may be unproductive recurrent wheeze. Chronic sputum production, any pattern of chronic sputum production may indicate COPD. Recurrent lower respiratory tract infection, history of risk factor we have already discussed, like tobacco smoke, active or passive smoking, smoke from home cooking and heating fuels, occupational dust, vapors, fumes, gases, and other chemicals, and family history of COPD and or childhood factors are also important. Now, what are the other causes of chronic cough? Because जैसे हर चमकती चीज सोना नहीं होती, ऐसे हर फूलती हुई सांस COPD नहीं होती. So we have to look for what are the other causes. We have to think of not tubular with the tubular vision, but think of widely. What can be the cause? For example, chronic cough means cough for more than 3-4 weeks is a chronic cough, and there can be pulmonary tuberculosis, there can be asthma, there can be so many diseases. So we have to some intrathoracic causes and some extrathoracic causes for the chronic cough. This can be asthma, this can be lung cancer, this can be pulmonary tuberculosis, bronchiectasis, left heart failure, interstitial lung disease, cystic fibrosis, or idiopathic cough. This can be the causes of intrathoracic causes. In extrathoracic, chronic allergic rhinitis, postnasal drip, upper airway cough syndrome, gastroesophageal reflux, and certain medications, for example, ACE inhibitors, they can also lead to chronic cough. So whenever you are declaring the diagnosis of COPD, you must think of these differential diagnoses and you have to rule out. What is the important? Important is that asthma and COPD, they closely mimic certain differentiating features I have already told, but this is the whole table. You can take the screenshot of this picture and you can very well differentiate whether this is patient of asthma or COPD. Age of the onset is very important. Usually early childhood, but may have onset at any age. So, as I said, majority of asthma they present in early childhood. COPD usually age is more than 40 years. Pattern of respiratory symptoms. Symptoms vary over minutes, hours, or days. Patient is breathless on Monday, but it seems all right on Sunday. This kind of scenario in asthma. Often triggered by exercise, emotions including laughter, dust, or exposure to allergens. While in COPD, dyspnea is persistent and progressive, particularly during the exercise, with better and worse days. Lung function. So spirometry or pulmonary function test can be a very good tool for differentiating where the FEV1 FVC ratio is important. If it is less than 0.7 or 70%, it is called obstructive airway disease. But if FEV1 is reversible, means you will do the spirometry or pulmonary lung function before and after 2 puffs of salbutamol. 20 minutes after 20 minutes of 2 puffs of salbutamol, and then you will see what is the post inhalation. After inhaler, what is the value of FEV1, and before inhaler, what is the value of FEV1, and you will see the change. What is the change? If change is more than 12%, it is asthma, and less than 12% is COPD. Similarly, the past history or family history, you must take the similar illness in both diseases. Time course is spontaneous, improves with treatment. So asthma can improve spontaneously also with bronchodilators also, but you see the progressive worsening even with treatment. You cannot stop the disease process in COPD even if you are giving the best treatment of the world. Exacerbation, risk of exacerbation can be reduced by treatment in asthma. So you can very well control asthma and there are hardly any exacerbation, barring a few patients. In COPD, exacerbation bound to come with change of season, with comorbid condition, with more of air pollution and so many other triggers. Airway inflammation, eosinophilic inflammation is the hallmark for the asthma. Sometimes it can be neutrophilic, but majority of the time it is eosinophilic. While in COPD, it is neutrophilic, of course, inflammation, barring a few percentage of COPD where there is a component of asthma also, allergy also, and that's why you can have the eosinophilic inflammation also in combination with the neutrophilic inflammation. Now, here these are the three patients. You can see the first patient is asthma, the other second and third patient, they are the two patients of COPD. In COPD, we have two poles of presentation. One is called, the middle patient is called the pink puffer syndrome. It is the cachexic patient, loss of fat, loss of protein, and patient is usually more dyspneic and having pulse-led breathing, mainly emphysematous disease. While the third patient is called mainly chronic bronchitis disease, where the patient is not able to maintain oxygen. So that's why he's having more colpulmonale and more heart failure, right heart failure, and that's why a lot of water retention is there, and that's why patient appears to be obese. A lot of swelling is there, over pedal edema is there, and anasarca is there. So these are the two, of course, phenotypes, major clinical phenotypes of COPD, mainly emphysematous disease in the middle patient, and mainly emphysematous disease in the middle patient, and mainly chronic bronchitis disease in the third patient. And asthma patient, there is no finding on inspection of chest where chest is normal. So just open the clothes and you can recognize on inspection only this is the patient of asthma and these are the patients of COPD. So this is the algorithm. Patient presenting with dyspnea, 40 plus, having history of some risk factors, having family history, or having childhood history of recurrent lower respiratory tract infection, associated with chronic cough and chronic respiratory production. And one or more of these indicators, you have performed the spirometry. You have in between, you have done a chest X-ray, which is the showing signs of hypertension. Otherwise, it is normal. Post bronchodilator FeV1 FVC ratio is less than 0.7, which is indicating the obstruction, and FeV1 reversibility is less than 12%. Persistent airflow limitation confirm the diagnosis of COPD. And this is the spirometry, the same thing it is showing here on. What is the gold classification of 1, 2, 3 or mild, moderate, severe, and very severe? How you divide the severity of the disease? So gold has got two classifications. One is called the severity classification, which is mild disease, moderate disease, severe disease, and very severe disease. Here we will use the criteria of FEV1, that is called forced expiratory volume in first second, very important criteria of lung function. And formula of FEV1 is very simple, 80, 50, 30. What is that? If FEV1 is equal to more than 80% predicted, it is a mild disease. If FEV1 is between 80 to 50%, it is moderate disease. If it is between 50% to 30%, it is severe disease. And if it is less than 30%, it is very severe disease. So formula of 80, 50, 30. Now, Gold has given, earlier there were A, B, C, D, 4 subsets of COPD. Now is only 3 subsets, that is A, B, E, and they have removed C and D. So what is that? It is basically the, academic and professional input from the developed, especially from the developed countries, especially from the India. We as physicians thought that in India, whatever the subgroups, 4 subgroups they have given, it is not palatable. And it becomes very complicated because in India, the doctor has to see the algorithm for the diabetes, hypertension, thyroid, so many other diseases, and of course, tuberculosis and so many other diseases. If you make the complicated algorithm for any disease, it becomes very difficult for the Indian physicians to cope up with all kind of complicated disease. So that's why we requested professionally also, and we produce a lot of evidence also that they should cut down and make it simple. So, and to me, frankly, it is still not simple, but it has simplified than earlier. Till 2022, for last 10 years, it was very complicated. And I criticize at every forum. Still, I'm criticizing. So, with due regard to the international authorities and guidelines, now they have grouped into the A, B, and what is A? A is as the less symptom and less exacerbation or no exacerbation. So, no exacerbation and less symptom is the A. B, of course, less symptom, less exacerbation, but E is more symptom and more exacerbation. So, depending upon the factors like the symptom and risk of exacerbations, as well as the grading of the gold according to the mild, moderate, severe, and very severe. So, compiled with this, they created of course, the A, B, and E group, depending upon the severity of illness, number of exacerbation, and the MMRC of disease. Now, how we manage COPD? You have understood how to diagnose COPD. Now, the question is manage COPD. So, always think of what is the culprit. If it is smoking is the culprit, the first treatment prescription should be stop smoking. Give in the vernacular language also, the local language also. If the patient is from Telangana, write in Telugu that please stop smoking. If the patient is from Tamil Nadu, write in Tamil, stop smoking. If patient is from Uttar Pradesh, write stop dhumrpan band kare, bidi cigarette band kare. First thing is, whatever the etiological factor was present as a etiological risk factor, you have to remove it. So this is the first tip for prescribing the treatment of COPD. Now, what are the goals for the treatment of COPD? Reduce symptoms and reduce risk. So first, I will discuss the risk. Yes, whatever the risk factor we have already discussed, cigarette smoking, passive smoking, active smoking, biomass fuel, any worker who is in a profession where a lot of dust is there, the vehicular pollution is there, construction worker, so many things. So reduce the risk, which is important for the disease prevention as well as for progression, and prevent the treatment exacerbation. So also important for exacerbation prevention and also important for mortality. So it reduces the disease progression, exacerbations, and mortality. All three are happened when you reduce the risk. Now coming to the for reducing symptoms, this is another goal. And for this, you want the relief in symptoms, improve exercise tolerance, patient can walk, patient can do his work, and improve the health status so that patient should be sound physically as well as the mentally. Because COPD is not only a disease of lung, it has got extrapulmonary manifestation also, psychological and some psychosomatic manifestation also. Now, this is how we treat. So for group A, you choose a bronchodilator. And what is the number one bronchodilator which should be used for COPD? It is the anticholinergic or muscarinic agent. And for group B, as the disease advances, you need another bronchodilator. And that's why you can use the combination of LABA plus LAMA, means long-acting beta-2 agonists like formoterol or salmeterol. LAMA means tiotropium or glycopyrronium. So you can use the two long-acting the anticholinergics and as the beta-2 agonist. So you can use on one hand the salmeterol or formoterol, and on another hand you can use the tiotropium or glycopyrronium. Now there is a group E, and there is a very specific indication for group E. Majority of patients you will treat by LAMA or combination of LAMA plus LAMA. Only in subset of population where the number of exacerbations are high, where the number of eosinophils are more in the peripheral blood smear, and where there is a history of associated atopy, childhood history of asthma, or coexisting asthma. So these are the only three conditions where you will use the consider of triple inhalation therapy. That is called LABA plus LAMA plus ICS. Here also it is written that if there is more than two exacerbations or moderate exacerbation or more than one hospitalization, or the peripheral blood eosinophil count is more than 300, then of course patient you will put on triple inhalation therapy. If there is a 0 or 1 moderate exacerbation not leading to hospital admission, or there is no exacerbation, then you can treat the patient with 1 bronchodilator. So basically, COPD has got 3 inhaler therapy. Step 1 inhaler therapy. That is, choice is LAMA, means anticholinergic inhaler. That is tiotropium or glycopyrrole. Single inhaler therapy in initially. Double inhaler therapy, where you use 2 bronchodilators, either in combination or separately, the tiotropium or glycopyrronium, and you can add on pharmacotherapy or salmeterol alone, in separately or in combination. Now, the third step is where I mentioned where you need the triple inhaler therapy, that is inhaler of containing tiotropium also, containing pharmacotherapy or salmeterol also, or containing 1 inhaled corticosteroid also. Now we have got single inhaler available in the market, double inhalation therapy, and triple inhalation therapy. All 3 kinds of inhalers are available. Decide the patient what you want to prescribe. All are available. How you, of course, this is the final algorithm. I would say that you have made the diagnosis on the basis of risk factor, symptoms, and spirometry. And you, of course, initial assessment done by FEV1 and symptom or COT or MMRC dyspnea, exacerbation of history, smoking status, alpha antibiotic and trypsin wherever you suspect, and you can do it at tertiary care center. And what are the comorbid conditions? Because you have to treat the lung condition also and extrapulmonary. So patient is having GERD, you have to treat. Patient having heart disease, you have to treat. Patient having carbonal, you have to treat. Patient having metabolic disorder, diabetes, you have to treat. Patient having osteoporosis or any arthritis or so many other diseases, you have to treat. Patient having psychosomatic disturbances, you have to treat. So all comorbid conditions should be taken care of. Please don't confine yourself to the management of lung problem or respiratory problem. Review the patient. And what can be the initial management of first prescription is smoking cessation. Vaccination is now very important. So of course, there is a vaccination guideline. Of course, you can use the vaccination. COVID is going on, so patient has to be vaccinated completely. At least 2 vaccination, first and second, if preferably third also for the COVID vaccination. It has to be influenza vaccinated. It has to be pneumococcal vaccinated. It has to be vaccinated for the varicella zoster. It has to be vaccinated for Tdap, that is called diphtheria pertussis also. So vaccination, smoking cessation, vaccination, and then of course active lifestyle and exercise. In medical term, it is also called as pulmonary rehabilitation. If you have the facility of pulmonary rehabilitation, you can use this. Otherwise, you can just promote the walking. Walking is the best activity. So active lifestyle, don't ask the patient to take the rest. No, a little bit exercise, a little bit of lung exercise like pranayam, a little bit of physical exercise like this, not vigorous exercise, not need to gym. Personally, I'm against the gym, even the healthy people. You have seen so many people are dying on the gym. They're having heart attacks in the gym. So please, I used to say, in history, who is the strongest man in the history? And people answer, usually young students and children, they answer, Hanumanji is the strongest man in the history of the world. Hanumanji have ever gone to gym? No, never. Sitaji or Ramchandji have the facility of gym? No. So please, I personally against the gym, even for the normal people, healthy people, and for the diseased people, not at all. So risk factor management, inhaler tactic is very important. You see, it is not your prescription which will provide relief to the patient. It is the compliance and adherence of your prescription. आप बहुत अच्छे doctor हैं. You are a gold medalist doctor. You are prescribing wonderful prescription, but patient is not able to cope up and compliant and adherent to your prescription. You are a useless doctor. So try to check, cross-check every time whether patient. That's why in our OPD, I ask my resident, always whenever you prescribe inhalation therapy or any therapy, ask the patient that please do come with the inhalers. I'll check you. And so management of symptoms and management of comorbid conditions. So smoking cessation is very important. The avoidance of risk factor is important. Vaccination is important. The risk factor management is important. Management of comorbid condition is also important. You have given very good prescription for the lungs, for the airway obstruction, but you have not taken care of GERD, gastroesophageal reflux disease. Patient will not be happy with you. You have given a very good prescription. You have not taken the problem of insomnia. There is a lack of sleep in the night. Patient will not be happy with you. And if you have not taken off his calcium level, vitamin D level, arthritis, the diabetes, hypertension, heart disease, I mean, you have to think of it in a 360-degree, and you have to manage each and every comorbid condition. And then, of course, your patient will be happy and say, my life had changed, doctor, after meeting with you. And that should be the commit for you. So, this is the simplified algorithm for treatment of COPD. This is developed by me. This is my algorithm, developed by for you people. Usually, I presented this algorithm to the family physician on the forum of Indian Medical Association. Very simple. A patient coming to you, you should have the stethoscope, you should have pulse oximeter, and that's all. So, with the three important equipment of a doctor, you see, during COVID times, we have experienced the importance of the pulse oximeter. Very important, because you have to decide whether this patient should be referred to the hospital or it should be treated at my clinic. You have to decide whether this patient required ICU management or the ward management. So whether during your OPD, during your, of course, hospital, if you are running hospital, in quickly 2 minutes, you can decide whether this patient is an OPD patient or would require admission in general ward or admission in ICU. How? Just come to the algorithm developed by me. COPD prescription prerequisite. What are the prerequisites? This is for OPD. The spirometry should be there, proper history taking, acceleration in last very year, you must mention, MMRC scale of dyspnea, oxygen saturation, absolute eosinophil count, so that you can whether double inhaler or triple inhaler, age of the patient, comorbidity of the patient. These are the prerequisites for any prescription, and you must take it. Now comes the role of pulse oximeter. If oxygen saturation, if you have seen my more than 100 videos during COVID time, if you have seen my video on the pulse oximeter, then I said, remember magic number 94, magic number 90. What is this magic number 94 and 90? Just come. If your patient's oxygen saturation is more than 94% or 94%, then if associated history of 0 to 1 exacerbation, pulse rate is less than 30 per minute, FEV1, if at all a spirometry report is available, more than 50%, absolute eosinophil count, if available, less than 300, you will advise LAMA or LAMA plus LAMA. Means either single inhaler therapy or double inhaler. SpO2 between 94 to 90, and if there is a history of 2 or more than 2 exacerbations, respiratory rate is more than 30 per minute, FEV1 is less than 50%, absolute eosinophil count is more than 200. Whatever available. If nothing is available, only pulse oximeter, and with the diagnosis of COPD, you can decide what can be the way of treating this patient. So in this situation, you will give LAMA plus ICS with beta-2 agonist, SOS basis, some antibiotic and oxygen and steroid and oxygen. So this is the treatment plan for the this oxygen saturation between 94 to 90. The last is when oxygen saturation is showing less than 90. Suppose you have the oxygen facility in your OPD. You just give the oxygen, and if it comes out to be 94 and going up, then of course you can treat. Otherwise, this patient is for admission in hospital. So that is how the algorithm. You can also take the picture of this, a screenshot of this, so that you can take the printout and you can have posted as a poster form. You can have in clinic, and even your nurse, your compounder, your assistant can take decision. Dr. Saab, this oxygen is less than 90%. So this will require admission. Should I refer to the nearby hospital? Even on telephonically, by just knowing the pulse oximeter, you can decide then and there that I have learned, I'm now confident, I have learned lecture of Dr. Surikant from King George Medical University, Lucknow, and now I can decide then and there that where this patient should be treated, on my clinic or hospital or ICU facility. So what bronchodilators in COPD they do? The bronchodilators, this is the evidence way, everything they are doing. So I will not go into the detail. All evidences A means top class evidence there that bronchodilator is the cornerstone for treatment of COPD. Why inhaled route? Inhaled route because orally, if you see the action will start after 1 hour. If you say the inhaler, then of course the action start within 2 to 3 minutes. So that's why you require the inhaled route, not the inhalable or other route. Factors to consider when initiating the inhaled corticosteroid, the triple, the third inhaler. Yes, strong support, history of hospitalization for exacerbation of COPD is there. More than 2 moderate exacerbation of COPD in last year. Blood eosinophil is more than 300. History of concomitant asthma, etc. There is a strong support for using inhaled corticosteroid. You can consider the use 1 moderate exacerbation of COPD in last year. Blood eosinophil 100 to 300. You can still consider. But against the use, when you are not used to inhaled steroids, I'm not talking of oral steroid, I'm talking of inhaled corticosteroid. Repeated pneumonia events, you should not use. Blood eosinophil less than 100, you should not use. History of mycobacterial infection means history of pulmonary tuberculosis, or there is a strong suspicion of pulmonary tuberculosis, you should not use the inhaled corticosteroid. Now, oxygen therapy and ventilatory support in severe COPD, basically these are the indication for the management of exacerbation. But oxygen therapy you can try. Again, there is evidence A that oxygen improves, but if oxygen, or even after oxygen supplementation, oxygen saturation is not improving, of course, this is the indication of the patient for ventilatory or ICU support, and you should refer it. So, supplementation for long term, certain patients they require long term oxygen, where you will say that you have now the time have come, then you should have the facility of long-term oxygen therapy at your home. 3 things I usually advise for those COPD patients who have frequent hospitalization. Number 1, you should have at home the pulse oximeter. You should have nebulizer, because during the exacerbation, your inhaler will not work. You will require nebulizer. So the second is the nebulizer, and third is the oxygen, facility of oxygen. So 3 things at home, they are required for these very severe COPD. And for COPD which have frequent hospitalization, ask him, 1 साल में आप कितनी बार भर्ती हुए? How many times you have been hospitalized? And if it is more than 2, you need pulse oximeter, nebulizer, and of course oxygen concentrator. 3 things to be required. Additionally, 4th thing is the BiPAP, which is not in your hands, which is at the hands of expert. Only at tertiary care hospital, in the medical colleges and a bigger hospital, they will decide whether this patient has the requirement of home ventilation, that is NIV. So you can decide if and for deciding the long-term oxygen therapy, you should have the facility of ABG. If you don't have the facility of ABG, you cannot decide that this patient requires home ventilation, home oxygen. Palliative care, end of life, and hospice care in India. We have already hospice care, means the care at home and care on hospital. Last time, end of life, palliative care. This is again at the tertiary care level. You cannot provide because there you require the nutritionist, social worker, psychologist, so many things you require, physiotherapist, so many, of course, the multidisciplinary team is required for this care. So palliative care is important for first patient. And this is all about the drugs and the end of care, palliative care, oxygen, everything. There is a non-pharmacological management of COPD also. What is this? We have already discussed the smoking cessation. Yes, it is the non-pharmacological treatment. Smoking cessation and pulmonary rehabilitation is also important thing. Vaccination is also important thing. So, and of course, a very important question asked, that is the yoga. What is the importance of yoga and pranayama? But there is importance. Our study, as well as study from the AIMS Delhi, they have shown that yes, but never advise pranayama yoga for the severe COPD or during the exacerbation. During hospitalization, during ICU, during exacerbation, you should not advise the yoga and pranayama. This is for stable COPD. In nutshell, COPD is a major health problem of the world and India too. Preventable and treatable disease. History of smoking, passive smoking, occupation, and exposure to noxious particles and gases is very important. Both pharmacological as well as non-pharmacological studies of treatment should be properly utilized to make a treatment holistic. Smoking cessation, avoidance to noxious particles or gases is very important. And vaccination is also important. Pulmonary rehab is also important. And these are all important pillars of non-pharmacological therapy. Thank you very much for your attention. If there are any question, definitely I am here to answer.
Hello. Hello.
Hello.
Yes, sir. Some questions are there. I will be posting in a chat one by one.
You have put into the chat. Okay.
Yes, yes. I will be posting the questions in the chat one by one.
Okay, post it.
Hello.
खैर हो गया अच्छा आज असल में अंकित भी नहीं था
Hello.
How to define a cutoff point for the SGRQ for good and poor quality of little of COPD patient. Okay, so for the quality of life, there are a lot of questionnaire. So I would not suggest that you go for a long questionnaire. The simple thing is that you have taken care of nutrition, you have taken care of psychological problem, you have taken care of the other psychosomatic factors, and you have taken care of comorbid condition. Definitely patient will have the good quality of life. It is not the questionnaire which will satisfy the patient. It is the feedback with the patient. If you ask, now you are happy, then it is, I don't believe in questionnaire, I believe in patient feedback. Yes, any other question? Your comment on the home high flow therapy for sure. Yes, that's a good question. The oxygen therapy in question. If the patient after ABG, if the patient PO2 is less than 55 millimeter of mercury persistently, and if the patient has pulmonary hypertension or heart failure, right heart failure, then definitely he's a case for LTOT, that is called long-term oxygen therapy. So I think by just doing ABG, you can decide whether this is the patient for oxygen therapy or not. Any other question? Okay, what are the roles of emphysematous destruction and small airway management COPD? Wonderful. So now there's two types of intervention for these emphysematous bully and lung destruction. One is through the bronchoscope, that is called part of the intervention pulmonology, which pulmonary specialists, we are doing it. A lot of things are coming up, stenting and a lot of other things are coming up, and then ballooning, stenting and so many things. A non-bronchoscopic procedure, that is open, the other surgical biopsy, which the cardiothoracic surgeons are doing. So depending upon the situation, whether patient fit for bronchoscopy and bronchoscopic procedures, we will do the intervention pulmonology procedure. Otherwise, we refer to the patient to the thoracic surgeons. This is called lung volume reduction surgery. It may be bullectomy, it may be lobectomy, it may be so many other lung volume reduction surgeries. Any other question? Yeah, what is the gold criteria for staging COPD? I have already, I think, given in my PPT. Gold criteria, yes, I have already given. Mild, moderate, severe, and very severe. 4 criteria, formula of FEV1, 80, 50, 30.
Sir, we are done with all the questions now.
Okay, thank you.
Thank you very much, sir, for your time.
Thank you. And remember in future what instruction I have given in.
Yeah, sir. Extremely sorry for what happened.
This is shows your casualness. You have not seen. And share the, of course, this one, my flyer at least 3 days prior so that I can correct.
Surely, sir. We will take
details.
care of this.
You should not search the Google. You should not take from the internet. You take me, what are the credentials, what should be put on the flyer.
Oh, okay, sir. Okay, sir. Okay.
Okay, thank you.
Thank you, sir.